excited about today's seminar, in part because of the topic and in part because of all the work that Jim Bost has been doing to try to advance us in our abilities to use the EMR as a research resource. And so I think most of you know Jim, but I'd like to give him a sort of a formal introduction. Jim joined us in March of 2017, so about 2.5 years ago, as the Chief of the Research Division of Biostatistics and Study Methodology. As you know, the division works very closely with the CTS-IPN to provide biostatistics and data management services, and consists of both Ph.D. level faculty and master's level statisticians and data managers. Prior to coming to Children's National, Jim was the director of the Outcome Center at Children's Healthcare in Atlanta, and there he really did some very cool work building a center that provided data warehousing, reporting, and analytics service for CHOA's service lines primarily, also their departments and strategic initiatives. And so coming to Children's was a possibility of kind of putting the accent on the different syllables. There it was their service lines, here it's more research. And I think the latter sort of fits Jim better. I've known Jim for quite a number of years when he was at the University of Pittsburgh, where he was the lead coordinating center PI and co-PI for two kidney research disease studies. And he managed a team of analytics specialists and biostatisticians, and really was a really important force as we struggled with how to use imaging studies to come up with biomarkers, predictive biomarkers, for the progression of the dominant form of polycystic kidney disease. Fast forward all these years later, that biomarker was critical for the clinical trials that were done that led to the approval of Genarc, which is the first targeted therapy for ADPKD, approved last April in the U.S., several years ago in Japan, in Europe, and in Australia. And so Jim is very capable. He's very hands-on. He's very, I think, real-world, but has a wonderful knowledge of biostatistics and data management. And so one of the things that we've been trying to do in our CTSA is to figure out how can we use our very special relationship with Cerner to develop tools and platforms that allow people to ask questions about this incredible, from this incredible treasure trove of patient information. And so the latest tool is Healthy Data Labs, which would work in concert with an entity that we're calling a data lake that's going to aggregate data from our medical record and a number of other resources. And Jim is going to tell us how he's doing that, and more importantly, how you can use it as a research resource. Dr. Bost.
Awesome introduction. Thank you, Lisa. All right, I guess let's get started. So special thanks to the team of folks that have been working with us on this process. So it comes to, we all started this with like kind of 4 main questions in mind, or things that we wanted to be able to do. We wanted the ability to mine our EMR data to identify potential patients for future research studies. We wanted to be able to use a tool called HealthFacts for monitoring. And what HealthFacts is a de-identified database of admissions from about 500 Cerner hospitals. And we currently have access to that data and are doing some really cool modeling work predicting mortality and severity of illness, which is another talk I'm looking forward to giving you all in the future about the work we've done there. And right now, we do have that, and it is sitting on a Azure cloud. But you will see that as part of this process and our collaboration with AWS, we want to bring that into the children's data lake. We also, really wanted to think about automating the pool of data for research and registry support out of the EMR system, and to be able to migrate that directly with our data from RedCap and Opentica that we use for prospective data collection. And we wanted to create a place to store other data that could be useful for you as researchers, such as the PIS data, which comes from CHA and has quite a lot of data around the I think it's over 40 freestanding children's hospitals that I've used in the past to do some research work. There's the Age-Cup Kids database, which is a huge database of hospitalizations around pediatric populations that I promote out there for folks interested in doing some initial assessment of rare diseases because of the size of the database. Health facts we've talked about. We're also looking about implementing and bringing in PEDSnet data, the Tory database. So, it's thinking about how we can bring in other sources of data to contribute to research. And I put down there as well as our own data registry because, we have found in our initial review of the EMR system that there's some important data that right now isn't being put in there, but is being put into your registry, like certain cardiac procedures. We went looking, searching in the EMR, couldn't find them, but when we went to the registry data, there they all were. So our key will also be able to bring in registry data. When I was at Children's Healthcare of Atlanta, one of my team's responsibilities was amalgamating all the registries that were at the hospital, and there were over 30 registries that we brought together across all the service lines that were, being used, and having a lot of the data, both within fields in the EMR and the notes contributing to those registries. So that's also part of what this process will hope to help. So the first thing they asked us to do in this process, well, let's make a business case. And so we worked to do that. So thanks to our folks in grants and contracts, I was able to figure out that in fiscal year 17, we had about 931 studies. I removed the small studies. I restricted those that were identified as the Children's Research Institute, or now Children's National Research Institute business unit. I took out the basic science studies that wouldn't involve patients, and I assumed, based on some research we did in the literature, that around 18% were currently using nurse data abstractors to pull data to support those studies, which gave us 25. And in addition, nurse data abstractors are current drivers for these population registries, so that's even an additional cost that we didn't even include specifically in the model. And then we did some research on the average number of subjects. We said 60 subjects, average number of visits, 3, average number of forms, et cetera, counting down to how much time it takes. And basically, what we found that for that, for those studies, 25 studies on average, is costing CRI about $1.25 million in terms of data abstraction out of the system and paying folks to do that, to populate studies. And again, if you counted all the work being done by these abstractors for registries, it probably comes close to doubling that cost. So if we could build a process that could pull that data automatically out of the system to populate these, it would be a huge cost savings to the institution, and that money could go towards lots of other things that you as researchers might want to use it for. We also had to present some cases of individuals that we talked to that would definitely benefit from this effort. This is a small list that continues to grow, and these and others will help us in the beta testing process of what we're going to be doing moving forward. So I want to step back for a minute before we launch into our solution, and I'm throwing up a few slides that were done at a recent CERTER conference by Dr. Eric Peterson, who really kind of hits the nail on the head about electronic medical record data for clinical research. And as he's fond of saying, the growing revolution is transforming the everyday practice of medicine, owing more to laptops than lab coats. This is an information revolution that will change forever the way doctors make decisions. So where are we kind of right now in the world with respect to EMR and medicine? Well, we know that EHR penetration is almost complete. What its uses are really focusing on are billing. It really kind of has limited operability for research and sometimes poor data completeness because, clinician users aren't thinking about that this data may be being pulled for research. So they're putting in what they may need to know to make clinical decisions, but that might be not everything that we need for research. What could be considered maybe professional impact is lots of face time with patients, because you're having to take all that time to enter the data into the EMR system, which potentially could increase clinician burnout. But the way I think the way data entry has improved with these EMR processes over time, that's hopefully not as much of an issue as it was in the past. And then what's the return on investment? Well, right now there's limited use for research. There's limited use for using it for decision support, and all that data in there could be used for all the quality, efficiency, and safety assessments that we do here. So what do we need to do to move that forward? Well, we need to be able to easily access the data and set up national data standards and data mapping so that for researchers, we as data scientists know how to pull the data for you. Plus, a lot of you are doing multi-site trials, so we need to have a system in place that the standards and the way the data are set up are similar across sites. We also realize that a lot of the data that you have is sitting in the notes, and that is not something that we can automate in the process, but what we can do is pull those notes out and use tools like natural language processing to at least try to help you hone down and find those pieces of information. And one of the folks on my team, Martin, is doing an evaluation now of other natural language processing tools out there, because we will eventually be pulling in all the note data into our children's national data lake. So we're excited about that. We're going to need, moving forward, to really stress data completeness, real usage of the AMR for all of the information. He suggests what he calls janitors or data informatics janitors that are keeping things up to date. Obviously, we need storage space and access. So if we're going to be pulling all of this data regularly into a framework that you can assess and analyze, we've got to make a cloud-based storage and computing environment. And we need to be able to have people here that you can work with that have the right skills to be able to mine and model some of this data for your research. And so we need to have real data scientists with skills in machine learning and phenotype validation. So that's, we went back and forth for probably a good 8 months to a year trying to come up with lots of different solutions to how we could do this. And what we finally decided with the help of our Bayer Institute and CERN partners to try to bring and use what's called Healthy Data Lab. So it is a research-ready version of Healthy Intent. And for those of you who don't know what Healthy Intent is, it basically is the EMR data pulled into a database structure that we can abstract from. It also contains other data. It contains some registry data. It contains some data from our outpatient clinics. But it's basically the source that we go to without having to dive directly into Millennium, which we don't like to do for security and other reasons, to be able to pull data for you all. Unfortunately, it's currently not an easy process. We can only go in and look one record at a time. We can't really pull chunks of data. It's cumbersome. It takes long. As it stands now, was not the ideal solution. So what CERN is doing is creating what they call Healthy Data Labs that pulls the Healthy Intent data set into the system and puts what's called the FHIR data model standards on top of it, which are much easier for us as data scientists and data managers to pull the data that we need. And the FHIR standards are being adopted across most EHR platforms, so I can tell you that Epic is also looking at using the FHIR standards, so it's standards that could allow us to be able to be consistent in what we would pull from the system when you're working with other children's hospitals. We do have the Cerner expertise as a dedicated partner, as Lisa said, to assist with understanding the data structure and the data pools. We also have the right programmers here within my division and Elio's division to be able to have the skill set to pool the information out for you. So we've got the people here ready to get this moving forward. And that's the standard slide that Cerner puts out about what Healthy Data Labs can do for you. It can access, it can help you analyze for cohort discovery and exploration. You can use these open source tools for testing models and algorithms. You can use it for validation, and you can use it for implementation. I have several other slides on Healthy Data Labs if you wanted some more information, but so where are we now after all this process? So we've signed our contracts with Cerner. We've signed our contracts with AWS. And you say, well, why do you need Amazon Web Services? Well, Amazon Web Services is what Healthy Data Labs sits in. That's the tool that Healthy Data Labs sits in or is part of. And we're exploring using the Amazon Web Services space for our entire Children's National Data Lake. So we had to have all those in place. We've had our kickoff meeting. We're expecting to have Healthy Data Labs available for beta testing by the end of the year. So we may work with some of you that have research pool needs that we could use to test case this. And again, I'd like to recognize that this truly is a team effort between my group, between the BIRD of the CTSI, between our informatics folks, both at BIRD or both here and at GW, Cerner Kansas City, and our FAIR Institute. So we will keep you abreast of the progress, but we're very optimistic we'll have something up and running by the end of the year. So that hits question one, and that gets us off on our journey to get this done. But we need to be able to do these other things. We need to be able to pull that data, and try to automate the process. We need to be able to store other data that we might want to use, like health facts and HCUP kids. And so while we will have a system in place to start being able to access that data for you, we have to figure out how to fill in these other pieces. So that's why we call it the Children's National Data Lake. It would be one source of truth for your information. It will have the right securities in place. It will be able to, in the future, be able to, as I said earlier, use clinic notes, real-time machine learning data, hopefully imaging and imaging recognition software, registry data, a place where all of that can be stored with the right levels of security for you to be able to access. So in the real nice world, it would be this great puzzle piece where we just got do and bring in this last piece, the live EHR database access. And I have to thank DK Kim on our team for putting most of these slides together, and his genius mind to figure out how all of this stuff interacts is absolutely amazing. Unfortunately, this is where we really are. Things aren't quite so nice, and trying to figure out where all the puzzle pieces fit and work is currently a challenge for you all. So we've got to fix that. So we want to build what's called the Children's National Data Lake. So on the left, you can see the sets of data that we have now and will initially work for in the future. So we talked about the health facts data, that is this huge database of Cerner institutions that we get updated every 6 months. In a few months, we'll hopefully have Healthy Data Labs up and running as a source. We have what's called I2B2, which is a de-identified version of Healthy Intent that we use for different purposes here, and I'll walk you through one of the main purposes we want you to be able to use that for. And of course, you have the data in REDCap and OpenClinica that you are using for research purposes. And there's also this database called AppShrine, which is basically a group of 50 institutions, I2B2 data sets, that we also have as part of a CTSI source. Then all the way over here, these are some of the tools that are available right now for exploration. So To access the I2B2 data, we have what's called the web client of I2B2. So that's a tool, we are trained, you could be trained in to mine this data. We have Trinetics, which is our preferred tool that I2B2, or that sits on top of I2B2, that we want you all to be trained to be able to start exploring our data for learning things like, I want to do a study that has children with sickle cell disease that have had an admission at least a year ago and that are on hydroxyurea. Well, we want you to be able to use that tool, go into I2B2, figure out how many patients there actually are right now, and see if a future study would be feasible for you. And then, of course, we have our REDCap tool, where you're now able to pull data and summarize data, and Shrine is the tool that sits on top of this ACTS database that folks on my team are trained to pull data for the ACTS source. So what do we want to do? The first thing we want to do is create a user-friendly portal for all of you folks to come into to help move you and guide you forward in this process of getting data or getting answers about data for what you need. We want to be able to take, and we've made great progress already, take the tools and the data and merge them. So these, our REDCap sits on top of our REDCap app. I2B2 has web client, I2B2 web client, and Trinetics sitting on top of it. So we've already done that piece. Once you've used that data and learned that you want to do a study and you have it planned and funded, we want you to be able to work with our data scientists to start pulling the data out of the system that you might need. And so our data scientists use tools from AWS's platform of tools, the AWS Notebook system, to pull that data out of these Healthy Data Lab and Health Facts. And of course, we're already pulling data out of REDCap and storing it, a lot of times in the statistical package that our analysts need. And we run reports off of REDCap right now. And so, the final goal is to try to build this process that once we do all that for you, you have a space that's just yours within the Children's National Data Lake that you can go into and access the data on a regular basis for what you need. So let's walk through sort of a couple scenarios to try to explain a little bit more what I'm talking about. So the first case is that first one I talked about, that you need to know if there really are the right number of patients available for what you need to do. So you would visit the portal. The portal is going to ask you, have you tried to use some of these data warehousing apps? Do you know Trinetics? Have you done it before? If not, you'll work with us to set up your Trinetics account. You will get trained on using Trinetics. And that's the people you would work with there are what we're calling our Children's National Data Lake data agents, and they'll get you all set up. Then you'll start working. You'll input. Basically what you do with Trinetics is you input various exclusion or inclusion criteria to come up with that set of patients that are what you're interested in, and part of the training is to have you very closely and walk through examples about what an and statement means versus an or statement, because that can really, down your process when you're trying to pick that subset of patients, can make a huge difference. And so we'll get the extraction criteria working, and then we'll ask you, well, you need to go to the next step and need data from the EHR, and you'd be like, nope, all I needed to know was how many patients there were, now I can go write my study, work with my biostatistician to get that power calculation and analysis plan, and move forward and get funded. So that's the simple case one. When we're all up and running, hopefully everybody in this room is going to be trained in Trinetics and is going to be able to start doing that searching of the data yourself. And again, that's de-identified, so we don't have to worry about IRB at all, really, in this process. So case two is, well, now we might actually need some data extraction. So you've already visited Trinetics. You realize that I can use this data within the system either right now for a retrospective study you're working on or planning. So you do need real extraction from the EHR. So that's another place in the portal that we're going to build where then you can go and request data science services to do that. And so you would meet with the data scientists, figure out what you need, what you have to pull, what is available, what other sources we might have to go to, could be registry data as well as Healthy Data Labs data, and we'll do the right processes to pull that available data out for you. Then we'll always have to think about in this process, do you need this data to be identified or can it be de-identified? And if you want identified data as part of that extraction, then we have to go through what we're calling our Children's National Data Lake Security Agents, who will most likely be our IRB folks. We need to make sure that you are approved to be able to have identified data moving forward. Once you are approved, we'll execute the scripts that we need to do, we'll validate those scripts, and we'll, again, put it in your folder in the Children's National Data Lake. And let you know that you can retrieve your data. Again, this is our thought process is, going to take a while to get there, but I really truly believe we're going to be able to do it. We'd also even like to potentially have you all be trained in even more kinds of things to help in this process. So, we also want to think about, automating the extraction process. We want to be able to build something that would pull data out on a regular interval, depending on what comes in new for your patients on your clinical trials or observational studies. So you already moved forward here. You need some data out of the system, and we'd like to automate the process. So, if you want semi-automated extraction criteria, you'll request validation. And you have taken the time to use these extraction templates that we want to build. So what do I mean by extraction templates? Well, you might know that every time one of your patients in your study has a new lab, you want to be able to lab result, you want that data to come in to your folder in the system. So we'll build a tool that might be called the lab extraction tool, and you'll go down there and choose which labs you want to have access to. And we already know which IDs are your patients. And so once you've helped us build that, we already know part of what would be in the extraction process. Perhaps you want to know for each of your patients on your study the mean blood pressure, systolic blood pressure every day. We'll have a place where you might check that and help us figure out, or maybe, you don't need it every day, you want it weekly. So there'll be a series of questions in this tool that we want to build that allows you to help us even more figure out what we want to automate in the process. And again, those extraction templates that you help us build, we'll go through the data scientists, we'll use our regular tools, direct database access, and this is where AWS has some exciting piping tools and software available that we're going to use as part of that automation process. That was really key when we were trying to decide to work with. Do you have the tools? Because Cerner didn't have the tools, but AWS does, in our understanding, have the tools that's going to allow for this automated pulling. And it's the same final steps: identify data for extraction. If it's identified data, following your security agent, and then getting you the data. Any questions at this point that, I know I'm throwing a lot of thoughts and ideas that you have at all in this process before moving forward? Kevin?
So when you extract data like that and do the query, does that data still sit in that warehouse there and you're just getting basically links to that data? It's not copied into a database that gets set up for you in that case, is it?
For you mean you or me?
Yeah, well, or it's creating your own database that you then manipulate. When you do the query and you extract data, And does it actually populate, a database in this data warehouse that you can then do your further analysis on?
Correct.
And it does,
Yep.
okay.
And you will have access to it, and whoever you designate as part of that
And what
study.
about image data, which sets that can be very large too? Are we gonna be able to accommodate?
That's our hope. I mean, we've talked to the folks at AWS and Cerner about this, but we've even talked internally about the ability for RedCap to be able to get that. And so our powers that be within the Bear Institute know that that's an important thing we eventually need to be able to do with RedCap, so.
Very nice.
So Kelly, if I could just make one quick, so I
Yeah.
think most of us know that NIH for large data storage is moving to AWS. So it won't be server farms, it'll be
Yeah.
in the cloud. And the database, it's not that you're gonna have your own little database, shiny, gold leaf, that kind of stuff on your desktop that you can, rub like Aladdin's lamp. It's gonna be in the cloud.
Right.
Okay, just so that everybody realizes that.
I'm not gonna take it on my laptop and get it stolen.
That was the implicit message. Thank God. I'm looking at you.
But the piece that we will be able to export it so that into our own statistical software, right? So that we can run our own analyses, but then it
Right.
would just stay on the cloud.
It's just the data themselves, you can pull it, and actually it turns out, Monica, as we've been going through all this, stunning to me, putting stuff out there, costs peanuts.
Right.
Moving it back and forth, not so peanut-like, more like fancy peanut butter. So that's one of the things that we're working on.
But that brings up a good point about, this isn't free. And, luckily, through the generosity of the CTSI and the Bear Institute, we have this funded for a full 12 months. We also have a credit with AWS that should serve us well for the next year or so to do these beta testing and setting up the automated system. But eventually down the road, when you're planning your budget for your studies, and hopefully in that place of where you had data extractors, you're going to be paying a fee for us to automate this process for you.
So that leads to several questions, but especially for like residents and fellows who may not have research budgets, do they get cut out of all of that? But the question that I actually had was the kind of data that we currently have stored in our EMR is terrible. It's inaccurate, and even using natural language processing, different residents, different fellows, different millennial attendings come up with all these weird words for technical terms. I can think of 4 or 5 different words for pneumonia that our fellows and residents use. And I'm just curious as to how natural language processing can get through that, because it doesn't look like we're going to be able to standardize what everybody uses in terms of the progress notes.
We could probably give you a whole nother talk on how natural language processing handles those things. And like, for example, when I was at a conference, they were trying to figure out how do we use that to know if the patient vomited. And, it could be, you look for vomit, but you have to look for no vomit. You have to look for, synonyms for vomit. I mean, these natural language processing systems have to think about all of those different links when they
Even abbreviations like PTN,
yes,
pneumothorax.
right. And
But that's all built into the way the natural language processing.
They keep coming up with new words every week.
And you update the software.
But this is not, I think that Craig makes a really important point. I actually, from kind of the center director of CTSI, I want to make, so number one, the natural language processing issue is now a global issue.
Right.
So you could be in a financial market, you can be in, you pick an industry, right? And so this is why it's not easy, because, it's why there have to be all of these efforts to sort of build these algorithms. And maybe Mihaela could talk about that a little bit more. But this is a common problem across information. Okay, so that's the first thing. The second thing, your point about our residents and fellows going to be cut out of this. I want us to think very carefully about turning the paradigm around. If we want to empower our trainees to use data, big data sets, in asking research questions, then we have to figure out a way to avail themselves of this.
Right.
So, for example, when I came here 7 years ago, There was no financial model for the REACH program, which is wildly successful, to use the services of biostatistics. And through a variety of different approaches, we'll bore you with the details, we've worked that out. So Jim's business model doesn't fall apart, and we have some rules, but our REACH program continues to grow in its success because people know how to work with a biostatistician. So I would say for data management, for example, we're doing a partnership through the IDDRC with Boston Children's and the University of Washington. You want to ask how many patients are in your system? University of Washington has that down to a dollar amount. And so if we then think about surveying what kinds of REACH projects our residents do, or what kinds of data projects our fellows do, and then we build that into their training budget, that's the way to go. Not just, because I don't want people to start to push back on funding this by saying, oh, but it's going to leave people out. No, you just develop a model that accommodates so we can make this not only sustainable, but that it can grow.
Going back to the natural language processing, certainly with large pharmaceutical databases, they use a MEDRA dictionary, and they have multiple synonyms. So there are probably already some computer programs that can help you find that emesis is the same as vomit is the same as puke because you're quoting what the patient said.
Oh, yeah, Mark should probably tell you, there's lots of free natural language processing tools out there and software, and there's lots of pay. I reviewed for Corey in their Pure Methods panel. Every review cycle, we're reviewing one or two natural language processing tools that somebody wants Corey to help pay for. It's just trying to figure out what's the best that we're working on now. Yeah.
So, getting back to one of the initial points is that the data that you get out of it will really rely on the data structure that's underneath everything, right? So you've been talking a lot about being able to search on this side, which I think is good and is long overdue. But on the other side, so this is really talking about discrete data fields, right? So I guess my two questions are, one, how far away are we from actually getting kind of all the notes and PDFs and non-discrete data elements into be able to extract that, because that's critical. And number two is there needs to be, on the working with Cerner side, the ability to create and standardize more discrete data fields into our EHRs as we put this. And that is a massive bottleneck that is insanely slow and cumbersome. And I know that's not your bottleneck, but for this to work, right, we need the other side to work also to be able to create those discrete, data forms and stuff in our clinical practice, which will then inform this. So.
And Bear Institute has dedicated at least two individuals to this project, a project manager that will oversee this, and what they're calling a project data specialist. And I think that person's going to help with a lot of that. And we're also bringing together what we're calling our clinician advisory team to help us deal with, making sure we understand the data, making sure, seeing how, they're the best to evaluate how valid this data is that we're pulling out. But you're right, no matter what hospital I've been at, that's the bottleneck. There's a huge list of additional things that you all want to collect, and they kind of got to do it one at a time to try to get it into the system.
And the access to notes and non-discrete data,
I'm hoping within a year we're going to at least have the download. We do have a tool right now here at Children's called Endeca that has downloaded and analyzed that data, but it's not a tool that we are supporting anymore in the institution, and it's old. But we are kind of using that as a model moving forward with how we'll be able to do that in the Children's National Data.
So to further answer your question, Cerner as a company actually invested a lot in that because of that.
right.
They're catching up with that. They have more advanced in certain elements of your question. In fact, a lot more.
Yeah.
So they're racing to catch up. And they have invested a lot in people and resources to achieve exactly that. So how long? We're probably talking months, maybe up to a year. But it is happening. So I'm cautiously optimistic.
from the perspective of having been working on this, I think it's actually closer to 18 months. One of the things is that there is really such a notion as a tipping point. You know, we can have all these conversations. We're not going to have conversations for 3 years. And we set up a whole stake to try to get around some of these things because we didn't have these tools. Once people start to use it, once this advisory committee comes together and starts to identify and prioritize what people need to have access to, I think that those real-world demonstrations of saying, I need this to apply for this grant. Here is the potential return on investment for my getting it. Here's the potential financial cost if I don't. Becomes much sharper. Putting together that list of people who might use things, some of it was conversations we had. Someone coming with a discrete issue, I think, is part of the impetus to move this forward. So what I'm trying to say is, this is an effort that has been slow to get momentum, but I think the reason that Jim so much wanted to give this talk now is we're on the cusp of it really beginning to accelerate.
I mean, just another example of how this can be used. I mean, you're right. Where I was at Children's Healthcare of Atlanta, much of this is already in place with the EPIC system, and so the majority of the data needed to populate the U.S. News and World Report, stacks of information needed to evaluate the hospital, was able to become an almost automated process there. And we all know how much time and effort all of your divisions put into populating the data for that.
Similarly to how you're going to be including imaging data, which I presume is, for example, MRI, just another system incorporated in this kind of, will you be including like heart monitor systems, H2, cell data, is that going to eventually be included in this? Means a lot of that.
If there's a need, we'll add it to the list, absolutely. And of course, there's always the whole thought process around the genetic data. And we're working on another component with our whole Walter Reed move and another group of things that our informatics team is building to handle that genetic data appropriately that would also eventually feed into this.
So could I just pick up on a quick, this is a really important one. One of the things around all this, and so people have needs, you should be able to articulate that in a, I want to do this. I mean, they use business models all the time here. God knows I'm very guilty of people who write business models, but it actually has a benefit when you go to the C-suite or write SBARs, you know? But just to put something down, this is what I want to do, and this is what I need. And just to send it to Jim, so that it's something that's fresh on your mind, and you're then in play about the things that you need. Because wearables, we spend all this time in the Sheikh Zayed, and if you know wearables that people are actually going to be using for research, can they put their wearable data into the data lake? We should be able to, but we have to really be thinking about it in a very intentional way to bring these things online.
All right, just have a few more slides. So this is the big flow chart of the entire process. That sort of brings together all of those pieces. And so these are just sort of a few summary slides. So the portal will provide this information on database and tool availability, provide you this dashboard, provide project-based access. There's a lot of things that are going to go on in the back end of this process. You know, as we're moving forward with Healthy Data Labs, we already have the team of folks here with the right skills, both within our groups outside of Bear Institute and the Bear Institute. So we're moving forward, and you know, we're going to need those folks as well as probably some more in the future to be able to truly build what we're talking about here. You know, again, we want these agents to help you in the process. So I have a group of folks on my team that would be your first line agents. I've got two groups on my team that would be your data scientist agents, plus we have folks from the CRIO's office and from Bear Institute. So we're building the right people in each of these processes moving forward, which is why I get more and more excited about it. So again, your data science team, your database. Now I debated throwing this one in here because it's starting to get a little technical. But the reason I kept this slide in the process was to sort of tell you the kind of people that we're building behind the scenes to make this work. So again, this is that initial dashboard that we're talking about that will give you general information on all these databases and what they can do for you, like what's NHCUP and what might you be able to use that for, and what's the size, and some lists of publications and abstracts that have used this for different purposes, as well as that portal to move forward through the data lake process. You know, we've got, within our group, we'll be building query processors that will compose these right queries and manage the request and translate the interface into being able to use it for different tools. We have our own Explorer process that's going to check the status of projects. We have to manage the authentication, the permissions, the scheduling of data extracts, the automation of the process. And again, we want to be able to build that query builder for both you to be able to use to help in the automated process and us to be able to do that effectively. And so we've also done our homework to figure out who we need to build along each of these processes moving forward. And like I said, we have a lot of these people already, but we realize the need, and we're working, again, with Bear Institute to figure out how, and the CCSI to figure out how we can move forward to get the right people we need to get the job done. So this last slide is kind of the way I think about this, and I don't know if any of you shop at Amazon, but I think I go overboard in my Amazon shopping. But I guess that's putting it nicely. And I like to send things to the locker over here in Whole Foods because I've had stuff stolen off of my porch where I live right now. So I kind of think about what each of you are going to have with us is your own Amazon locker that's going to be, you know, only you having the combination and access to it to get your stuff. So you'll come into the dashboard and kind of your request booth, your request portal there. Behind the scenes, we're going to take all that you need to figure out, get all that you need, build it in the data lake, store it appropriately, and deliver it to your locker on a regular basis for usage.
So if we sign up for Prime, do we get next week?
Well, maybe, you know, if you're willing to pony up an annual fee, we could prioritize there.
Is there a thought about time frame from request to delivery that you're going to try to keep up with? Is that too early?
Yeah, we're too early. I mean, you know, it's certainly our hope that the more we can automate, then that's not really an issue. Right now, healthy data labs will be upgraded or updated with new data every 2 weeks. We'd like to get that done every week. So at least that's as close to the real-time data that we have.
But you don't expect it to be like some things that passed with Cerner and the Bear Institute, that it was weeks or months before we could get results of things. You don't expect it to be that way, do you? What's that?
It's a new day.
I hope so. This is awesome. This is absolutely awesome.
So can I just ask, I mean, they've worked incredibly hard. Can I just ask people, because one of the things that's going to be very important to make this real is your training.
Right.
So there are lots of different models for training. We can set up sessions, we can have lunch and learns, you come with an issue and we work through it. A sense from the group about what would be the training approaches that you would find most helpful?
So I've done the healthy analytics training, and it's not helpful at all. What they show you in the training is the first time I went, they didn't even want us to use the real data that we would pull from, but didn't tell us that it wasn't the real data. So we went back, and we were pulling data that was not complete, and it was not specific to what we were doing, and there wasn't really any customization to it. So we were going in and we were seeing all these variables, but it was.
How long ago was that?
How long ago was it? I think the last one I did was over a year ago. We did tell them that it didn't help, and they set us up for an individual training, but it took us about 6 months to get them to finally give us that individual training.
So for you, individual training, but it sounds like I don't care how you do it, I just want to work with real data.
Yeah.
So I'm seeing this come together as I'm formulating my question, not some, exercise.
Yeah.
Okay.
And a data dictionary?
And that's pointing out all the problems with healthy intent now for researchers, that we hope would help.
And that's why we're going to healthy data now.
Yeah.
Because I was just gonna surmise that you were doing this with healthy intent.
Mm-hmm.
Yeah. So.
I think an online module, I think the class is difficult, so I think that an online module with examples where you actually click through the tool with a few examples, something that you can do kind of in 15 to 30 minutes, just that you get your piece, and that gives you access.
Right.
And then, if you want, there can be kind of follow-up classroom or open hours time for individual one-on-one things. But I think a lot of these, I personally like to just get a little direction and get access and be able to play with it.
So that's really important, because we have a limited manpower, right? So where are we going, what syllable are we going to put the accents on, right? Is it going to be lunch and learn trainings? Is it going to be, oh God, I hope not, but a slide, presentation? But it depends on the community and what people feel comfortable with. What I would just say to you is in Cornerstone, the training, if you talk to HR, they gave us a list of how you do it and, a certain circumscribed thing, and there was such variability in the way people wanted their training. So just to plant the seed, so I personally, what you're suggesting makes a great deal of sense to me, but not everybody learns that way. So we just want to get a sense so that when we push it out, we don't pick one and then leave people behind.
I think there really are two different groups. Those that regularly do research, who are going to be using it on a routine basis, can get training and go in and do it. But then the others, I'll go back to the fellows and the residents, nurses, and even many attendings like myself, who I'm now doing more research, but I might be doing a project every year or so, right? I may not, that for me, it might be a just-in-time type of learning versus people who are regular researchers, whose primary job is research, that would need to do a different kind of training.
So I think, Chris, to answer your question again with limited manpower, this is a model we've used for the past 5 or so years, is we're going to target the researchers. And the reason that we're going to do that is because those are the people who, that's their job. This is what they have. But one of the things is we're going to try to do this in a really thoughtful way, to have something akin to herd immunity, right? So that you may not have gotten your vaccine, that's a very dangerous analogy, but you may not, so you may not have gotten your training, but the people around you have gotten training, and that may be another way to then figure out what's the best entree. Because if people are only using something on a kind of an ad hoc basis with long intervals between use, then a formal training session for them has to take on a different complexion.
Yeah, we had a tool in Atlanta that we called Population Discovery, or PopDisco, that was a dashboard that we used for researchers and clinicians to access, like the Trinetics tool on top of IQB2. And each service line trained 1 or 2 people on how to use that. And everybody else within the service line, when they had questions about the data, they had a dedicated person within their service line.
I just don't think that the herd immunity analogy will work well with, say, the cardiology division, or cardiac ICU, or critical care, because there aren't many people in those divisions that are pure researchers, or mostly researchers.
I understand, but Naomi set up a wonderful model with the clinical research division group that partners. So there could be ways that we can partner, but it doesn't have to be just only from your herd. But again, because then also one of the things that allows us to do is to understand how we then can take those people who do it episodically and bring them up to speed for what they need.
So what this is great, so what I would suggest is maybe having a session with the program directors of the various training programs within the institution, and say, look, this is the issue, this is the model that we have, we need for you to help us create a situation where your very intermittent users would have access to training by some other people, train the trainer kind of thing. But I think that since education and training is a huge part of this institution, we need to find a model that will help them whether it's building it into their budget, like you mentioned before, which I think is a great idea, and